Welcome to Sky Women. I'm your host, Dr. Carolyn Moyers, a wife, mom, and board-certified OB-GYN. This is a place to educate, empower, and inspire. Join us each week as we share the power of women's stories. Real women, real stories, real inspiration. Put on your stretchy pants. Let's get going. Welcome, Sky community. Welcome back to another episode of Sky Women. Today, we have a special guest with us, Angela Fishman, PT. She's a licensed physical therapist and the proud owner of My Pelvic Therapy, an innovative virtual physical therapy practice that's dedicated to preventing and treating pelvic floor problems in women. With over 20 years of specialization in pelvic health, Angela is deeply committed to empowering women by offering discreet at-home solutions to address the often stigmatized and challenging conditions which stem from pelvic floor problems like bladder leakage, pain with intercourse, and pelvic organ prolapse. And so let's talk about all of those items today, actually. I know Angela and I were talking beforehand. Welcome, Angela.
Thank you so much. Thanks for having me.
Absolutely. So we were talking beforehand about all of these different issues that affect women through the lifespan and how oftentimes we are doing a better job than we previously were in the postpartum period in regards to getting women to pelvic floor physical therapy. But there's still a large majority of women who have gone through pregnancy and childbirth and not rehab their pelvis.
Correct.
And it shows up later in life.
It absolutely does. Yes. And the problem with it showing up later in life is people think they just have to live with it because it's so common. So many people have issues and there's so many myths around what's normal after you get older or you've had a baby or maybe you've never had a baby, but you have leakage. People think, all sorts of things. There's so many myths out there about when this area doesn't work well. So yes, trying so hard to get the information to people at a younger age so they understand and can take more control over this area of their body.
Yeah. So let's talk about that a little bit. Like specifically, let's back up. Pelvic floor physical therapy done virtually. Talk to us about that. How is that happening?
Yeah. So it seems kind of like a not common sense thing, right? How do you do pelvic floor therapy via telehealth? But it actually has served as a really good tool for a lot of reasons. First off is access. So there's not many pelvic floor therapists around, and the ones that are around often have waiting lists. So many people have such access problems to getting to a pelvic floor physical therapist, or they're quite far away. Pardon me, they might have to drive. I had people seeing me, they drive 3 hours to come see me and 3 hours to go back home. I mean, it was really pretty crazy.
Wow.
So access is one of the reasons that I treat via telehealth. But another really big one is just the intimacy factor. So all my patients are fully dressed and I'm treating them as a full-bodied person. So
right.
And they know that ahead of time and they are more comfortable because now they're at home and they're not having to be in a busy clinic and be around people that are doing things that are not as embarrassing. Oh, someone's treating their knee, someone's, treating their shoulder. So when when you go to a busy clinic like that to treat such an intimate area, it's very intimidating. It's hard enough to just pull the trigger and make your appointment anyway. But when they get there, it's so intimidating. So telehealth can really kind of ease people's concerns. And then the final thing is you don't necessarily have to be right up and in somebody's pelvis to help them with how it functions. Because it's like, I don't have to touch your shoulder to help you with shoulder pain. And even though the pelvis, the muscles are more hidden, they're not really that hidden. I can see how you're using your body. What do you do when you cough? What do you do when you get up from the chair? I can see how you're using your muscles, including the pelvic floor. And are you using them correctly where they're protecting you, or are they not strong enough or not coordinated enough to protect what needs to be protected? And so it's actually, you have to be very focused visually. And I have found that it's actually enhanced quite a bit how I treat patients.
Fascinating. Okay. So it's nice to have increased access, especially for people who are in more rural areas. So I think that's wonderful. So let's talk about how first of all, the pelvic floor is this little sling of muscles, right? And I don't think that a lot of us give much thought to our pelvic floor. Even when you talk about kegels, you're like, am I actually doing them? Where is my pelvic floor exactly? How is it functioning? But if we think about that sling of muscles, right, we've got our urethra there, we've got our vagina, we've got our rectum. So it's functioning in continence and in sexual function and all of the things. So it's really a key part of our overall general well-being, in my opinion. So how can pelvic floor physical therapy help with urinary incontinence? And can it help with more than just stress urinary incontinence?
So
which is only cough, laugh, sneeze.
Yes. So the two main kinds of incontinence that pelvic floor therapy work really well with are stress incontinence, like you just described, where you cough, you sneeze, you lift your baby, you get up out of a chair, you exercise. All of those are about managing pressure coming down to the pelvic floor. And so strengthening those muscles, or so some people have too much tension in those muscles, so they don't function right too. So there's kind of a misconception that it's all about weakness in the pelvic floor, but it's really more about, are you too tense or are you too weak? It just depends on what's going on. We need to optimize those muscles. So that works really, really well for stress incontinence. And then the other one is like overactive bladder / urge incontinence, because many women have to rush to get to the bathroom or are going to the bathroom pretty frequently, every hour or even more, or they're getting up at night 2 or 3 times to urinate. So that would kind of go under the overactive bladder umbrella. And if they have leakage before they get to the bathroom, you would call that urge incontinence. So pelvic therapy with that works really well because the pelvic floor muscles help to kind of modulate and keep under control how the bladder is functioning, because they're connected through some reflexes. And then part of pelvic therapy is not just those pelvic floor muscles, it's all the other muscles that are impacting that area. And then teaching somebody, what are all these other things you're doing that maybe are not healthy for your bladder? Maybe sipping on coffee all day long is going to irritate your bladder more than you know and is impacting your overactive bladder. Or maybe you're drinking after dinner quite a bit and you're not tying it into your mind that that's why I'm waking up 2 times a night or 3 times a night. So there's a lot of behavioral things that we address as well as a pelvic therapist.
So how many would you say with like a simple stress urinary incontinence would you see resolution of their stress urinary incontinence? Is it 100%? Is it 80%? Like what would you say?
I like the way you said simple. So it all depends. If it is just simple stress incontinence, yes. So that might take just 3 visits with me, but you need to do those exercises over 4 to 6 weeks.
Right.
So if you've only temporarily, and I mean like months to a year or 2, had stress incontinence or leakage with those coughing, sneezing instances, if you give yourself 4 to 6 weeks of doing the right things, you pretty much should stop leaking. It's when you have other things layered upon it that it gets harder. Maybe you're older and you had hip surgery and you actually have a lot of weakness in your hip, which very strongly impacts your pelvic floor. Well, now we also have to do some rehab with your hip too. And so we're going to add some exercises in there that maybe that quote unquote simple stress incontinence person doesn't need to do. But if you've got other issues, then we need to address those as well. And so it's like every layer of something else going on will add a little bit more time and a little bit more effort to getting to where you can be dry again. With urge incontinence and overactive bladder, that also depends. How long have you had it for? Again, what are your muscles doing? Even though it's not as straight of a line A to B muscle strength to overactive bladder, it is very important what those muscles are doing. Because if you have a lot of tension in your pelvic floor, that's a lot of chatter back to your bladder, and that could very strongly be making your bladder overactive. So now we have to do things to relax and let go of that pelvic floor. Lots of stretches for the muscles that are in the area that increase that tension, and that can take some time. So we really determine it's the first visit you ever see a physical therapist. They'll fully evaluate you and tell you, okay, here's what I think. I think it's going to take this many sessions, and it's going to take this dedication of you at home doing these exercises. But about 4 to 6 weeks is a really good kind of guideline for rehabilitating most things to do at the pelvic floor.
So in general, you think within 4 to 6 weeks, you should, if you're going to see improvement from pelvic floor physical therapy, you should start to see that.
Yes. And it may not be your maximum improvement. You might need to do it for 12 weeks. If you've had leakage for 10 years, it's going to take you a little bit longer. But yeah, for sure, you should see between 4 and 6 weeks. And if you don't, that's when we're having a conversation with a physician saying, here's where we're at, and this is not working the way we expect it to. What are some other options?
Yeah, right. I like that. Okay. And then when it comes to pain with intercourse, so we see this a lot where it may be that it's been from the beginning, maybe patient had a difficult time inserting a tampon, or maybe it's something that has developed over time. I've even had patients who waited until marriage to have sex, and then they're surprised by the fact that things don't seem to want to operate correctly. And it's very painful with insertion. And so it's very infrequent that they have sex. And, maybe they've seen somebody, or maybe they tried a vaginal dilator. What are your thoughts in regards to that? And how do you typically approach vaginismus or a hypertonic pelvic floor?
Yeah. It's a very devastating situation. Vaginismus, more than we would call dyspareunia. You can have pain with intercourse and not necessarily have vaginismus. Vaginismus often has a thicker layer of fear related to it, or there's more to it there that sometimes you have to unravel before you start just directly treating the pelvic floor. With dyspareunia, which is pain with intercourse, also, you might see maybe somebody had a vaginal birth and they tore a little, and as that scar healed, it's still tender. And so when they have,
or they're postmenopausal and
they don't have that estrogen level that keeps that tissue a little bit more comfortable. Yeah, there's so many reasons that can kind of connect with it. So you really have to drill down to figure out, all right, what's the major cause? If it was somebody that has what we would call primary dyspareunia, they've never been able to have intercourse comfortably. Well, then we're going to treat that differently than a woman that either is menopausal, or because that's going to definitely be involving our medical team to make sure that the tissue itself is healthy. And then we deal with the muscles too. Because if I deal with the muscles and the skin is still in terrible shape and it's painful, I'm not going to make an impact. And then if it's somebody that has a scar issue, we're going to try and get that scar more mobile. So it really depends on what that cause is to figure out how to treat that.
So with somebody with primary vaginismus, though, like they had difficulty inserting a tampon, they were never able to have comfortable penetrative sex. What are typical treatments for that?
Yeah. So the first session is a lot of education, because if you could imagine going through that, there's a lot of shame. There's a lot of what's wrong. That's probably the biggest thing, that once you start to build some trust and people start really opening up and telling you the feelings that they're having, they think something's wrong with them. I just want to do this. Everyone else can do it. It's in the movies. I see it all the time. How can I not do this? Like, it's
poorly depicted in the movies. Come on. Not all those women
are poorly depicted in the movies. Absolutely. But it's always like, oh, it's so great. And so they feel like I'm broken. What is wrong with me? That's a high hurdle to get over. You have to get over that, though, to have some healing. So there's a lot of education. I have a pelvic model where I bring it out to show muscles so that they understand the muscular component of it. We bring the partner in to show them, because a lot of times the partner, it feels like it's almost about them. They're being rejected. Why can't she be with me in this way? I don't want to hurt her, but really, is she just not love me? Is she, there's a lot of really complex there. And a lot of times I'll actually recommend that they see, I've got some people that I work with that help with the relationship piece of it, and just kind of that acceptance of the situation. So we've got some psychologists that are really, really helpful with it.
Yeah. That's what I was going to say is doing a multimodality. Yeah. Thank you. Disciplinary approach is definitely going to be in everyone's best interest, right? If you've got somebody who specializes in trauma or sex therapy who can help with that, because once they experience pain, we get this neural pathway, right? Where they're anticipating pain. And so then it's hard to relax and be in the moment and anticipate any amount of pleasure, right?
Exactly. So once we kind of get started, they understand what's going on a little bit better. And we're giving them some physical exercises that are impacting this, not right into the pelvis yet. We just want to start reaching so they get connected to this area of their body, because people get kind of very dissociated there. This is such a negative area for them with what's going on. So it might be hip stretches. It might be back stretches. It might be relaxing your belly more because there's so much tension. So it's kind of one of the first things we do is get you started with some exercises that can really kind of start to integrate that area into your concept of yourself again. And then we do eventually usually get to something called dilators, which there's all different shapes and sizes of what these are. They're graduated sizes of things that you insert in the vagina with the intent of over time to work up in those sizes. And there's some that are really soft and flexible. There's some that are firmer, that where you can actually do stretches. So depending on what we feel like the woman would benefit the most from, that's where we start. And some women have to start with a Q-tip. So like when you start using dilators, the most important thing is that there is no pain with it. And so you need to start with something that is so small. And it doesn't matter where we start. You just got to find that with that person. You start with something that's so small that there's no pain, there's no fear, they feel comfortable. And that has to be your starting point. You can't start with something where they're feeling some stretch and pain, because it just keeps rebuilding and reinforcing what you were talking about, those neural pathways of that pain. So, and then once you get a little traction with that, it works really quite well, because now the woman is completely under control. There's no partner or spouse there. They're going at their own pace. They're getting in positions that are comfortable for them, and they can slowly make that progress and really kind of get to know this part of their body and what feels okay, what doesn't feel okay, even in positions and angles and things, so that they can feel more empowered when they do try and reintroduce themselves into intercourse. And because that is one thing, often not everyone does this, but I usually tell them, okay, we're just going to take intercourse off the board right now. You can be together intimately in other ways, but we're going to take a break from intercourse, because we want to really break this cycle and build some confidence. And we'll talk about how we'll reintegrate you into being sexually active again. But for right now, we take intercourse off the board. And that kind of gives them a lot of relief, because it's such a stressful thing for them, you know?
Yeah. Yeah. So do you have a general timeline where you'll have them trial the dilators?
That is super, this is an awful answer, because it just depends on somebody.
Specific.
So the hardest thing is getting the traction in the beginning, finding that level where there's no pain, letting them get the confidence. Because a lot of times, a lot of emotion also comes with this. So they'll start something, and the actual physical insertion might not even be the hardest part, but they might have these very strong reactions to the process. And you have to let them work through that and get them extra support if they need that, and bring the partner in if you need to do that. So sometimes that beginning part can actually be the most difficult, you know, and then once you get a little bit of traction, it might go much faster. There's other people, especially if they've had a period of time where they had pain-free intercourse, they might go much quicker, because they're getting back to where they were, where they did not have pain. So
back to their baseline.
It really just so depends on the woman and their experience. Did they have trauma? You know, did they go through sexual assault at any point? Or were they in a threatening or violent relationship? I mean, you're working through all these things because of this very intimate part of their body.
Sure, absolutely. Okay, so let's switch gears and talk about pelvic organ prolapse and how pelvic floor physical therapy could potentially impact pelvic organ prolapse.
Sure.
When we talk about pelvic organ prolapse, we need to kind of identify what that is.
Yeah. So pelvic organ prolapse is where things are going where they shouldn't be. So you've got your pelvic organs, which in a woman is going to be the bladder. Then you've got the uterus, and then you've got the bowel. And when any or all of those start to slip down into the vaginal canal, a woman might experience something like vaginal pressure when they're on their feet for a long time. Or if it has dropped low enough, they might actually like wipe themselves in the bathroom and feel something there, which can be very disconcerting, because nobody likes to feel a quote unquote bulge or something that's not supposed to be there. So that's usually a quick call to the doctor to get some reassurance of what's going on. But if you feel that bulge, that can be really pretty scary for someone. But all that's happening is those organs are dropping down a bit into the vaginal canal, and it's pushing that vaginal area down and out a little bit. And so from a pelvic floor standpoint, we want to get our hands on you to teach you, okay, here's how you handle pressure better. Because if you think of like a hernia, that's something where like the abdominal contents are pushing out where they shouldn't be. And people kind of know the concept. Oh, if someone lifts a lot and has a lot of heavy lifting, they might get a hernia. Well, this is like a hernia. It's just a little bit different. It's down in the vaginal area, and it's the pelvic organs dropping down. So really, one of the most important things you need to do is teach somebody, well, how do I manage pressure now? And it's very related to stress incontinence. If I cough or sneeze and I've got pressure pushing down through the abdomen on my bladder, I might leak, or I might have more prolapse symptoms. So our role is really to optimize your pelvic floor muscle strength, which is a lot of times strengthening, but for some people who have all that tension, We're again relaxing that and lowering that tension level first before we strengthen. It's getting a lot of the abdominals and core stronger. And then it's teaching the timing of activating all of that. Before I cough, I've got to reactivate my core well to protect myself. Before I lift, the same thing, so that I'm protecting the pelvic floor, both from a stress incontinence situation as well as pelvic organ prolapse.
So I will say that these pelvic PT exercises are very effective. I've had patients who've come in either, postpartum period or at varying stages and had significant pelvic pressure or pelvic pain even. And when we assess that it's musculoskeletal and give them exercises to do, and they actually do them, the symptoms resolve. So that is really exciting. But I will have to admit that I have my own bias about, is it actually going to help pelvic organ prolapse? So I would think it's a grade 3 or 4 where it's actually pushing out of the vagina, that it wouldn't help as much as if we're being more preventive and doing it before we actually have that bulge.
So is definitely the
correct prevention? Or
yes, my thoughts are absolutely prevention is going to be better. I think all of us, I just got finished talking to a local high school last week, and they were fascinated by talking about the pelvic floor. All the boys and the teacher, who was a man, of course, did not know that they have a pelvic floor. So just learning, I have a pelvic floor, and very, very lightly touching on why is that an important thing to know. So even starting in the high schooler age is great, but specifically pregnancy is such a toll on our pelvic floor that's a great group to start talking with. And there's a push for this 4th trimester. People will call it the 4th trimester, which is right after you have the baby for another 3 months, to try and get more education so people understand, how do I care for this part of my body so I don't have prolapse, I don't have leakage, my back pain's less, because your pelvic floor is a part of your core, so it can affect pretty much
your thighs, your pelvic floor, your core abdominal muscles. I mean, it's all key, and it's incredibly weak in the postpartum period, and then you're going to lift this baby around in the car seat.
Exactly.
Yes.
And nobody tells you how, right? And most countries do have. I've been trying to dig up to see which countries get what services, and it's very hard to really pin it down. But most European countries do have some type of access to pelvic therapy, either in the hospital and or in the actual home after someone has a baby. And they're prioritizing pelvic health. And we in America are not prioritizing pelvic health. And it can affect really your whole lifespan, like we were talking. So it's such an important thing to try and prevent.
Yeah.
But to your comment about prolapse, if someone has a stage 3 or stage 4 prolapse, we're not going to quote unquote fix that. But a stage 1 or stage 2 has really good research behind it showing that symptom wise that it can improve. So even if you retest them standardly to see if the prolapse is there, it may or may not change that, but the woman might not have any of the symptoms. They might not feel any kind of bulge or vaginal pressure, and they can do a lot more without feeling those symptoms. So it becomes
I think that's fair.
An option that they can choose to see if they can get to where they feel comfortable.
Right. And potentially avoid surgery unless it progresses. So, Okay. Fascinating. So can you give us your top exercises that you like to do for the pelvic floor?
Absolutely. Yeah. So I have my magic 3. You got to do one for your pelvic floor. You got to do one for your deep abdominals. And then you have to do one for the coordination to manage pressure. And if everybody knew those 3 exercises, or at least knew about them, and it's kind of people know how to do squats and lunges, right? They know that will help keep their legs strong and healthy. These are exercises that everybody should know. So the first one comes with some caveats, because it really is the pelvic floor muscle strengthening, which people right away will say Kegel. Everyone should do Kegels, but not everyone should do Kegels. So it gets to be a little more nuanced. If someone does have pain is my first signal that maybe a Kegel is not for you right now. Let's talk deeper about that. But if we know somebody's weak, we've got pelvic floor muscle strengthening, and we want to do that long enough that it makes a difference. Many women will come to me and say, well, I've done Kegels. They don't work for me. Well, how did you do them? Well, occasionally I would squeeze those muscles, but nobody really showed me how to do them. Well, there's problems with all of this, right? If you don't know how to do them, how often to do them, you don't know, do I hold them or do them quickly? The answer is you do both. Then of course they're not going to work. So yes, Kegels they can play a very strong role, but you need to know how to do them. So we usually show them in sets of holding for 10 seconds, relaxing for 10 seconds, doing 10 times to get the more supportive fibers in our pelvic floor stronger. And then we show something called quick flicks, which are quick on, quick off, quick on, quick off. And you can go up to 30 for those. And that can really be helpful for the kegels. Okay. The second one is your deep core. So we want the deep abdominals. There's 4 layers of our abdominals. And so we want to make sure that we're getting the deepest layer. So a really nice, easy one for that is just drawing your belly button inward and holding for up to 10 seconds. And you can do this. This is a really nice one to do on all fours if you're pregnant. Feels great on your back. If you can't get on all fours, you can lean over a counter and lift your tummy, or you can even just do it sitting. In sitting, you can pull it in and relax it out. So that's a really great exercise. And then finally, there's the knack. So the knack is what's so important to learn how to address pressure. So if I cough, what's supposed to happen is my pelvic floor and my abdominals are supposed to come in quickly right before that pressure of the cough or sneeze happens. But it doesn't happen anymore. If you're having leakage, it's not happening. Or if you have prolapse symptoms, it's not happening well. So we practice. Okay, pull up and in, up on your pelvic floor, in on your belly, hold it and clear your throat and relax. And keep practicing that until it's very easy. Boom, you put it on and relax. And as long as you don't feel a downward pressure, then you're good. Your goal is to feel very balanced in your pelvic floor so you have enough support. And you're just practicing it enough till it gets so secondhand that from now on, every time you cough, open a heavy door, lift your laundry, take out your garbage, lift that heavy car seat, you're going to pre-tighten. So those are kind of my three magic pelvic floor exercises that I think help to really protect a great majority of people of what they need for their pelvic floor.
Sure. I like this. I think that we can use it across the lifespan.
Right. Yeah. We check all of those, no matter what's wrong with your pelvic floor. We're checking your ability to do those things. Yeah.
So if I have a post-menopausal woman who I am sending to pelvic floor physical therapy, and she is apprehensive, what would you say? What would your spill be for her?
So she's apprehensive about just going to pelvic floor therapy?
Yeah.
So, well, since I do everything telehealth, the first thing I tell them is they're fully dressed, which sometimes that is. So remember, right now, our older generation are coming from a generation where they didn't have access to all the information we all have on the internet. And so they're even more private about their body. So this is an area where everybody's private, right? But even more so, it's even harder for older people right now. And so reassuring that they're going to stay dressed is one thing. And I also just reassure them that it's not just your pelvic floor. These are things that might help. Maybe you have hip pain. It's going to help your hip. If we get everything balanced around your pelvis, it's going to help your hip pain. If you have back pain, all the same exercises that I'll be teaching you for your pelvic floor are going to be helping with your back pain, because that entire area has to work well together for all of those areas to be functioning great. So it's usually very education based. It's really just teaching them more about what this is, why we're doing it. And then also sometimes I'll draw the connection of, well, just like if you had shoulder pain or something was going around with your shoulder, I'm going to ask you to move it and I'm going to look at it and I'm going to say, okay, I think this exercise might help. So kind of normalizing that area and letting them know it's not really that special. It's the same kind of muscles. It's in this special private area. So it feels so different. When you think
right. Yeah. Yeah, I think a little bit of encouragement goes a long way, because once they do it and they see improvement, it's quite remarkable. So, so I think this is really enlightening, because most of the time when we've talked to pelvic floor physical therapists, we've had several on the podcast over the years. We've talked a lot about rehab in the postpartum period specifically, but not so much about stress urinary incontinence and vaginismus and pelvic organ prolapse. And this applies to our older population as well. I think that it's really important to see how, when we don't rehab our pelvic floor, kind of what happens down the line, and how prevention is the best medicine.
Agreed. Yes. I think we could be doing all the women a much better service if we could really talk about this much sooner. Yes, for sure.
Agree. I think everybody leaving the hospital with a baby needs vaginal estrogen and a pelvic floor PT prescription.
Yes. Even one. Because, once I feel like there's a lot of fear in that population, because they can read about all the millions of things that can go wrong. But they don't really get back, and they don't pull back and get empowered of what can I do to protect myself so that I feel confident going through my pregnancy and delivery. It shouldn't be such a scary thing. You should have the information. Yeah. You get all this information on how to take care of the baby, but not necessarily taking care of you. So it can be really helpful to know.
Yeah. Well, thank you so much for joining us today, Angela. This has been very informative. I appreciate you.
Oh, thanks so much for having me. I enjoyed our conversation.
All right. Until next week, be well.
All right, Sky community, thank you for listening to another episode. This episode was sponsored by Sky Women's Health. As a reminder, we're in the Dallas-Fort Worth area, and we help relieve back pain and pelvic pain in pregnancy and beyond. If you are pregnant and having pain and you feel like you have no reliable way to relieve it, look us up at skywomenshealth.com, request an appointment, and we'll call to get you scheduled. As a board-certified OBGYN with a Neuromusculoskeletal Medicine fellowship, I help you realign with hands-on drug-free treatment and relieve pain on the spot without medication. We'll help you maintain these results through your pregnancy and postpartum period. Every pregnant person deserves this, and we are so excited to serve you. You can find us on our website, as mentioned, or on social at Sky Women's Health, or you can call the office at 817-915-9803. That's it for today. Until next week, be well.